So, what is 1 Minute Preceptor? We're going to take 1 minute to tell you and another minute to show it in action.
It's a way of using opportunities in medicine as a teaching prompts. It's quick, efficient, and it focuses on key takeaway messages that improve clinical care. There are 5 components.
Number 1, ask the question. When a learner presents a case to you, rather than moving directly to tell them the plan, ask them, what do you think is going on? The best questions are one that inquire about understanding, rather than lists of differential diagnoses or tests.
Number 2, probe for supporting evidence. How did they get to that conclusion? What supported or refuted other possibilities? You're looking for clinical reasoning skills.
Number 3, teach. General principles, up to 3 takeaway, evidence-based pearls of wisdom.
Number 4, what was right? It might be that the only thing they did well was the presentation, but find what was correct and reinforce it.
And number 5, what was wrong? Correct mistakes in a supportive way. As with the last point, linking the discussion to good clinical outcomes for patients.
I like to use mnemonics to help memory, and for this I use APT, right and wrong. Ask, probe, teach, and then what's right and what's wrong. It's always apt to do teaching. Let's see this in action.
Danny, that was a good clinical presentation. So what do you think is the diagnosis?
I think she probably has costochondritis.
Right, so how did you reach that diagnosis?
Well, the patient's 25 years old with left-sided chest pain. She's a non-smoker and she's probably too young for it to be ACS. She had a chest infection a few weeks ago and was coughing a lot then. She's currently apyrexial and tachycardic, but I think that's due to the pain.
Okay, but don't forget that she's on the contraceptive pill. And even in young women, we need to keep in mind the possibility of a pulmonary embolism. It's always a good idea to take a contraceptive and family history, as her sister had an unprovoked DVT. It was good that you recognised cardiac causes are unlikely, and musculoskeletal pain can absolutely be a residual symptom of severe cough. But what else could support this being a PE?
Maybe the tachycardia isn't due to pain?
That's right. You missed those couple of clues in the history that made all the difference. We don't want to send someone home with a PE, as that could be catastrophic.
Okay, I'll start by organising an ECG, a D-dimer and some imaging.
Okay, that sounds great. And don't worry, Danny, we'll teach you how to take a proper contraceptive history in no time at all.